Hi, my name is Natasha Chauvel and I'm going to present on narcolepsy, especially the diagnosis of narcolepsy using neuroscience techniques. There are several symptoms of narcolepsy. The main one is excessive daytime sleepiness, even after an adequate night's sleep. A person with narcolepsy will usually feel refreshed after a night's sleep or day nap, but sleeplessness returns 1 or 2 hours later. They will usually experience disruptive nighttime sleep and trouble staying awake, concentrating, and functioning during the day. They may fall asleep or become drowsy at inappropriate times and places, including, for example, at school or work. They will experience disordered rapid eye movement sleep, and REM sleep can occur at any time. Elements of REM sleep can also occur during wakefulness, creating an intermediate state between sleep and full consciousness. Some people with narcolepsy experience cataplexy, which is characterized by sudden, emotionally triggered episodes of muscle weakness with preserved consciousness. These episodes may begin with weakness of the muscles in the face, followed by limbs and trunk. Cataplexy can range from slight weakness in the neck, knees, and facial muscles, and the inability to speak clearly, to complete body collapse. Speech may be slurred and vision impaired. Cataplexy can cause anxiety and fear and avoidance of situations or people that might elicit an attack in narcoleptics. Other symptoms of narcolepsy include sleep paralysis, which is the temporary inability to talk or move when waking or falling asleep for up to 1 or 2 minutes. People with narcolepsy may also experience hypnagogic hallucinations, which are vivid, sometimes disturbing dreamlike experiences that occur while dozing or falling asleep. Hypnopompic hallucinations are similar but occur when awakening. Hallucinations may be visual or auditory and last 1 or 2 minutes. People with narcolepsy may also experience autonomic behaviors while asleep, for example, talking or putting things away during sleep with no memory of these actions when awakened. There is a wide variety in the development and severity of these symptoms, and not all people with narcolepsy experience them all. There are several diagnostic tools that are relevant to narcolepsy. The Epworth Sleepiness Scale, an 8-item self-report questionnaire, is for screening, not diagnosis. Diagnosis usually occurs with a polysomnogram, PSG, followed by the multiple sleep latency test, that is the MSLT, the next day. The PSG helps rule out other causes for daytime sleepiness by measuring brain waves for an EEG, as well as eye movements, skeletal muscle movements, and heart rhythm. The MSLT lasts a full day, and the patient is encouraged to fall asleep for 20 minutes every 2 hours. The MSLT uses EEG to measure sleep latency, that is, how long it takes to fall asleep. The MSLT helps to distinguish true daytime sleepiness from physical tiredness. In addition, low hypocretin 1 levels in the cerebral spinal fluid are highly specific for narcolepsy. However, this test requires a lumbar puncture, and analysis of samples is not always readily available. The International Classification of Sleep Disorders 3rd edition contains the diagnostic criteria for narcolepsy. Type 1 narcolepsy will be diagnosed where the patient experiences daily periods of an irrepressible need to sleep, or daytime lapses into sleep occurring for more than 3 months, and low hypocretin 1 levels in the cerebral spinal fluid, or cataplexy, and a mean sleep latency, that is the time it takes to fall asleep, of less than 8 minutes, and on 2 or more occasions falls into REM sleep, that is a SORAMP, quickly on an MSLT, or 1 SORAMP on the MSLT and 1 on the preceding PSG. Type 2 narcolepsy is the same as type 1, except that cataplexy is absent and hypocretin 1 levels are in the normal range or have not been measured. The neuropathology of narcolepsy is not fully understood. However, as shown in the above figure, a loss of hypocretin and orexin-producing neurons is thought to be responsible for lowered motor cortical excitability and reduced activity in the histaminergic system in people with narcolepsy. The neurons that normally produce orexin help sustain wakefulness, and a loss of orexin-producing neurons leads to sleepiness and lapses in sleep. However, differences in orexin levels suggest that type 1 and type 2 narcolepsy may be phenotypically similar disorders with different underlying causes. Sleepiness and other symptoms are generally more severe with type 1 narcolepsy, and the diagnosis is more straightforward. Other neuroscience techniques have helped to understand narcolepsy and may eventually help with diagnosis. Magnetic resonance imaging indicates that specific anatomical changes may differentiate narcolepsy patients from controls, as well as subgroups of narcolepsy patients. In particular, an MRI study indicated that cortical thickness in the prefrontal areas is inversely correlated with the severity of narcolepsy, and that there are clusters of cortical thinning in patients with child or adolescent onset narcolepsy, but not those with adult onset narcolepsy. fMRI indicates a decreased volume of grey matter in patients with narcolepsy and cataplexy, especially in the hypothalamic region and thalamus. This is consistent with the loss of hypocreatinergic neurons. EEG with low-resolution brain electromagnetic tomography provides evidence that people with narcolepsy have functional deterioration of the frontal temporoparietal network of the right hemisphere vigilant system. Transcranial magnetic stimulation and diffusion tensor imaging have also provided information that may help understand narcolepsy. TMS studies indicate that there is lower excitability of the excitatory circuits and enhanced excitability of the inhibitory circuits in the motor cortex of people with narcolepsy, and that modafinil, a wakefulness promoting agent, has an effect on the cortical excitability in people with narcolepsy, possibly because it acts on the GABAergic inhibitory circuit. Diffuser tensor imaging studies indicate that people with narcolepsy have widespread microstructural white matter changes, including the hypothalamus, mesencephalon, pons, medulla oblongata, and that are not visible with conventional MRI scans. These changes are in accordance with the disturbances of the hypothalamic hypocretin system and its role regulating REM sleep. Diagnosing narcolepsy is difficult, and this graph shows that narcolepsy symptoms may usually begin between 10 and 25 years of age. Diagnosis often takes a long time, 5, 10 or more years. As the onset of symptoms past the age of 40 to 45 is relatively rare, the age of the first onset symptoms may be a factor in deciding on a diagnosis. The reasons why diagnosis of narcolepsy is difficult or complicated. One of the reasons is that poor sleep is common in the community, especially amongst teenagers, parents, and shift workers. Sleep disturbances accompany most medical and psychiatric disorders, and excessive sleepiness is often misjudged as laziness, lack of motivation, or intellectual inadequacy. Narcolepsy can be confused for insufficient sleep, or obstructive sleep apnea, or delayed sleep phase disorder, periodic limb movement disorder, shift working sleep disorder, the use of sedating medications. It has also been known to be confused with ADHD, especially in children for whom sleepiness may cause behavioural problems, as well as hypothyroidism and hypoglycemia. It is therefore clear that there are many challenges to the diagnosis of narcolepsy, which is often misdiagnosed or even not considered as a diagnosis. Excessive daytime sleepiness is common in other conditions, including obstructive sleep apnea. Whilst the MSLT is an objective measure of EDS, it has low discriminability between EDS of narcolepsy and daytime sleepiness in other conditions. It may be misleading because of the occurrence of false negative results. Type 1 narcolepsy is easier to diagnose than type 2, and low hypocretin levels are highly specific for narcolepsy. Therefore, narcolepsy is reasonably likely to be the correct diagnosis if a PSG indicates fragmented light sleep and early transition into REM sleep is less than 15 minutes after the onset of sleep, and the patient usually falls asleep in less than 8 minutes for a nap, whereas healthy people take more than 15 minutes, and the person has a REM sleep during at least 2 of the MSLT daytime naps. And references are provided on these 2 slides. Thank you for listening.